Good afternoon, everyone, and welcome to the PHSSR Research in Progress series, Cost, Quality, and the Value of Public Health. My name is Angie Carmen, and I'll be your moderator for today. We have a topic that is very timely to cover in today's session, Cross-Jurisdictional Shared Service Arrangements in Local Public Health, Research in Progress. Our two presenters are Dr. Susan Zahner and Dr. Kusuma Madamala. Dr. Zahner is a VILA's Distinguished Achievement Professor at the University of Wisconsin-Madison School of Nursing with an affiliate appointment with the School of Medicine and Public Health. Dr. Zahner has over 30 years of professional experience in public health and nursing. She teaches graduate students and conducts research in local public health system performance, multi-sector health improvement partnerships, and public health nursing education and practice. Dr. Madamala is an independent public health systems consultant with 18 years of experience in public health practice and research settings. She's worked with organizations such as the National Network of Public Health Institutes, the Association of State and Territorial Health Officials, Robert Wood Johnson, Michigan Public Health Institute, and the Institute for Wisconsin's Health. She is also an adjunct assistant professor and member of the DrPH faculty at the UIC School of Public Health and the Medical College of Wisconsin. So we appreciate both of our presenters being with us today. I'll remind the participants to mute your computer speakers and listen in on your phone. And we'll now turn the program over to Dr. Zahner.
Great. Thank you very much, Angie, for that nice introduction. And thank all of you who are signed into the webinar for your interest in this topic. I'd like to start out with just some brief comments on the background, aims, and overall methods for the study. I'll also talk about where we are in the process of this project, because indeed it is research in progress. And then I'll turn it over to Kusuma, who will talk about a part of the project, which is a follow-up survey to a baseline survey we did a couple of years ago, and the early findings we're seeing in that survey. We'll certainly welcome questions and suggestions work after the presentation. I wanted to start by acknowledging that this project is funded by the Robert Wood Johnson Foundation. This was in response to the PHSSR call for proposals last year. Our network, the Wisconsin Public Health Research Network, is also supported by a grant from our Clinical Translational Science Award, CTSA Award, at the University of Wisconsin-Madison. And finally, we also have a number of students who are able to work on parts of the project funded primarily through donor funds to the school. We know that interorganizational collaboration has been studied quite a bit over the past few years, and in other disciplines has been studied for many years. So the specific type of collaboration that we're interested in is commonly called cross-jurisdiction service sharing. And we're interested in this at the local level between local health departments and also between local and tribal health departments. In Wisconsin, just very briefly, our health departments are mostly at the county level. We also have some city and city-county health departments. And this is an independent kind of state where a lot of the authority for public health service provision is at the local level. So we know that having agreements to share services between local health departments is common in the U.S. based on NACCHO data, and it's also quite common in Wisconsin. We know this from a baseline survey conducted in Wisconsin by Kusuma Madamala, Nancy Young, and others in 2012. So from this prior work, we know that health departments enter into these agreements to improve quality of services, use their resources more wisely, and to respond to requirements or mandates for collaboration with funders or regulators. We also know that there's a number of factors that support collaboration through the many years of research topic in business and other disciplines. These factors are those listed. I think some or all of these factors are important influences on collaboration between local public health departments in So this study it builds on a prior study, which I mentioned, which was actually a quick strike grant, the National Coordinating Center from the Robert Wood Johnson So in 2012, we did a survey of our health departments and learned some basic things about how shared service agreements are being conducted here in Wisconsin. So this current study started in January 2014, so we're just past our halfway point in our funding, which will be completed at the end of this year. Wanted to note that the staffing for the project is myself and Dr. Madamala, as noted, and also Tracy Morochek is the project manager, and Adam Carlin is a PhD student who's working on the project. We also have a number of partners in this project. They're listed on the left-hand side of your screen there. The Institute for Wisconsin Health has been very helpful in providing our website and communication support, and they've done one webinar for us, and we'll be doing a second webinar in this project. Working with Jill Kruger from the Network for Public Health Law on trying to identify the legal aspects and coding mechanism for formality for these agreements. Also working with the Center for Sharing Public Health Services, and Gianfranco Pizzino is a part of our study advisory team. He'll be doing commentary on this webinar, and also work with our State Association and the Wisconsin Division of Health. On the right-hand side of the screen, you see listed our study advisory team. For all of the projects that we do through our PBRN, we do identify a study advisory team that includes local health department as well as others at the state level. So we have a nice list of study advisory team members who have been very helpful, essential really in this process of planning, conducting this. Thank them. So these are the specific aims of the project as we put them in our proposal. Again, since this is research in progress, we certainly haven't accomplished all these aims, but it gives you an idea of what we hope to do. Basically, we wanted to take a deeper dive, if you will, over what we've done in the past to really examine these agreements directly. We also wanted to understand if the agreements were just sitting on shelves or were actually being implemented and functional. And we wanted to explore the extent to which they are perceived to perform up to the expectations that who enter into the agreement have for them. We also hope to be able to look at the characteristics of the agreement and given characteristics of health departments to see if we can determine if there are features of agreements that support better implementation or better performance. And then as I've noted, we're repeating a prior survey to look at changes over time in these practices in our state. This graphic just gives you a basic idea of the conceptual or analytical framework that we're proposing to look at, and I'll talk a little bit more about our plan today. So this is the definition of a shared service agreement that we used for this part of the study. We actually are using a slightly different definition in the survey, but for this part of the study, this is the definition that we've used. We wanted it to be between at least 2 local or tribal health departments, and we chose a cutoff of the 2011 in order to gather sufficient numbers of agreements while also making it somewhat easy for participants to recall and talk about their motivations and so on for entering into the We were using a variety of data sources for this project. Shared service documents, so SSA is how I'll refer to them, that we gather from the health department. We created an extraction tool where we could pull from those documents information that we were interested in on the features of the agreements. We also created an interview guide for local and tribal health department directors and have done telephone interviews with them. We're using a secondary data source from our local public health department survey that's annually conducted by the state health department, and it's basically administrative data and population data and cost. And then finally, we're doing the online survey, and it basically repeating the survey we did as a baseline in 2014, and it kind of carried over a little bit into 20. Most of our analysis, of course, will be descriptive. We also want to assess relationships of the agreements on implementation and performance to see if we can tease out factors that might be important to include in an SSA to make it successful. We're going to be attempting to use a latent class analysis as a statistical method for creating groups within the database that are similar and classified as such. Thus, we might be able to identify higher and lower implementation of SSAs and higher or lower perceived performance, and then be able to identify factors that are associated with these classes of higher or lower implementation, higher or lower performance. We needed to do this because, of course, each of these agreements is unique, and yet they all have expected outcomes and either meet or don't meet those expected outcomes. This is a way we thought we could analyze this data as a group while not worrying so much about the fact that they had differing program areas that they were addressing. So just to let you know where we currently are, we invited 91 local and tribal health departments to participate. We have, at the time of the study began anyway, we have 88 local health departments, and we invited 3 tribal health departments to participate in the study. We actually have 13 tribal units in our state. The UW-Madison IRB would not allow us to just invite them directly because they are separate entities. And we needed to obtain written documentation from each tribal entity that they did not have or require additional IRB review before our IRB would allow us to contact them directly. Despite many and varied attempts, we were only able to get this documentation from 3 of the tribal health departments. So that's why we only included 3 of the 13. This is certainly one of the limitations and one of the challenges in doing this kind of research across lines like tribal or. First said about collecting the SSAs from these 91 health departments. 3 health departments declined to participate, and 13 reported not having any such agreements, so really weren't eligible to participate, and 12 simply didn't respond to our invitation. We collected a total of 126 documents. Of these, 24 were actually the same document, so sent by different parties to that agreement. And 17 didn't meet our definition or criteria for started. So we've ended with a total of 85 separate unique agreements from which we've extracted information. Now on the interview side, I started with the same group of 91 health departments that we invited to participate, and the same issues in terms of the ones who declined and didn't have SSAs. So we received consent from 63 health department directors to participate and to be interviewed. However, we've had 18 who did originally agree to participate, but were not able, but did not follow up and schedule interviews. And this despite many attempts over quite a number of months, and going back to the IRB to allow us to do additional checks of them. So the response rate from the health department is somewhat disappointing, and again is a limitation. I certainly understand how health departments are under a lot of stress. These requests for interviews came in the summer and into the fall, and as you know, there's a whole variety of different things going on in health during that time period. We completed our last interview last week. So going on then, some preliminary findings about our SSAs. This slide kind of hits a few highlights. We've extracted information from the 85, but we are doing some ongoing cleaning of the database. So the results I'm showing really are based on a group of 68 of the agreement. A large majority of the health departments are named as a partner in one or more of these 85 agreements across the state. So almost 85% of all of our health departments, 75 different health departments, are named as a partner in at least one of these SSAs. And 5 tribal health departments are named. The number of partners per SSA, as you note on the screen, ranges from 2 to 15, with a of 3.78 and a median of 2. The agreements that we have collected started anywhere from 2003 to 2014. The length of the term of the agreement was not noted in 30 of them, but on average is around a year, 13 months, and the median was 12. So most of these agreements are for a year at a time. We looked at what kind of information was in the agreements about a notice required to terminate the agreement, and 53 of them included a termination clause or information about how the parties would terminate, withdraw from the agreement. Time to terminate ranged days to 12 months, and in 22 of the agreements, termination was not clear or was not. The program areas covered by these agreements there's a whole variety of different program areas, but the most common are environmental health, emergency preparedness, communicable disease. The administration and planning agreements were mostly things around strategic planning or sharing of some kind of administrative service. So that's the program areas for most. The nature of sharing also had a variety of different types of sharing that was covered in the agreements, and each of the agreements could have more than one type of sharing that we were able to tell agreements. So the largest number is actually sharing services, providing services together, or services provided by one county in the other county. That's what sharing a service. Sharing staffing, maybe having one sanitarian who was partly paid for by both health departments. So those were the most frequent types of sharing we found. We look at the motivations that the health department directors had for entering into the agreements. You can see that the most frequently reported outcomes most frequently reported responses were to improve outcomes of services, increase their efficiency, expand capacity of their all health departments for providing a service, and to increase the quality. You can see that those kinds of motivations are more prevalent than the idea of actually making money or capturing more revenue, so the revenue side. Then the meets requirement often refer to the state perhaps having a mandate for a particular type of service, and collaboration being the only way that the health department could figure out how to actually, and also that relates sometimes to grant-funded projects. So a very, very preliminary look at extent of implementation. We measured this on a scale of 0, meaning no components of the agreement were implemented, to 5, meaning the agreement was fully implemented or operational. And this slide shows responses from 42 interviews involving 62 SSAs and revealed an implementation range of 0 to 5 with a mean of 4.53. So that's a pretty high on this scale of implementation. Again, preliminary findings, perceived performance. This was also measured on 0 to 5 scale, really trying to look at the extent to which the agreement succeeded in achieving outcomes that were expected of it, and 0 meaning no outcomes achieved, and 5 meaning all of the outcomes were achieved. In preliminary analysis, indicates a pretty high performance rate. The overall mean was 4.26 with a range of 0 to 5. So again, we hope to be able to compare performance by a variety of factors, including the type of the SSA, the nature, motivations, as well as characteristics of the health department, such as size or geography. We also asked a few questions that were more open-ended in nature, and the next slides are for that. So their experience with collaboration really was pretty uniform. I mean, 95% of the health department directors described some kind of prior collaboration with the other partner health departments. The most common types of prior collaboration reported related to collaboration-specific program areas like emergency preparedness or MDH, such as WIC, family, and environmental health. Those were the most common. Another theme here was about prior collaboration as being peer or collegial support. So comments that were about mentoring of the new health officer in the next, working together through a professional and serving as a support network for each other. Types of incentives to collaborate that came out of these qualitative questions were that collaboration really was required to get funding, that the state, which often meant the Division of Public Health, but also in the environmental health area in our state meant the Department of Resources, some way mandated either providing the service, such as through state statutes, or mandated, had a specific requirement to collaborate in a program area. And the third common theme was that collaboration was pursued as a strategy because it is believed to be or is valued as a way to strengthen public. Pretty much all of the interviewees were able to talk about positive aspects of collaboration. The agreements are perceived to expand capacity and improve services. This is things like enhancing the capacity of small health departments, enables them to do things they might not otherwise do. The second theme was about building relationships. Collaboration builds trust and relationships. It enhances more positive and more supporting relationships with colleagues. The idea that multiple minds working on issues is a positive thing. A third theme here was efficiency, that sharing staff and becoming efficient as a result of collaboration was important. Then the fourth theme here was about increasing the skills of staff. Of course, most of them were also able to talk about challenges to collaboration, and the most commonly reported ones were financial restraints that remained regardless of having a partnership or not having a partnership. And also the complexity that there's a fluid nature of these kinds of programs as changing situations and sometimes requires updates to these SS. And also that processes and ordinances and things are different in each county, and so there had to be adjustments related to that. Also mentioned here were some things, political challenges, priorities of policymakers being different across the organizations, staff and leadership turnover that may be challenging. These relationships are often built on trust. And then that the value of the collaboration to partners does vary. Where it's not very valuable to partners, that can be found. I also mentioned recommendations for someone else or other organizations that wanted to collaborate. And they talk quite a bit here about that there are good reasons to partner. Building capacity, it's a good idea, it's a wise use of resources. They also talked about qualities of a good agreement, that transparency about finances and expected outcomes, having clearly documented processes and roles, and having clear ground rules for the agreement. It was interesting that the idea of choosing your partners wisely out and knowing your partners, building relationships first, and doing this with agencies that you trust. And then finally, there was a theme of just do it. I mean, strong encouragement from to not be afraid to go ahead and do this kind of partnering that's worthwhile and to collaborate as much as. So I'd like to turn it over to Kusuma Madamala now to talk about the follow-up survey. Kusuma?
Thanks, Susan. So as Susan indicated, the follow-up survey is our final phase of this two-phase project. And right now we're at the stage of this. Primarily the follow-up survey was to compare to the baseline survey results from 2012. And as Susan indicated, that was funded through a quick strike to the Institute of. And the survey results from the baseline were published at the end. Our follow-up survey was launched in October, early October, and a majority of the study questions were the same as 2012. We have a study advisory team who reviewed once again before its launch, and we kept the same incentives since that seemed to work well in the past, which was a random drawing for a GP. Our protocol, we had 2 email reminders and phone follow-up. Unfortunately, while the survey was in the field, we had a variety of external events that local health departments were dealing with, like Ebola, influenza. We ran into the budgets, and suddenly the holidays were upon us. And so we had a very slow response, so we requested IRB to get approval for a 3rd email reminder, and that was sent on January 8th. The survey just recently closed a couple weeks ago, and we had a 69% response, which is quite a bit lower than what we experienced in 2012 when we had a 92% response rate at that time. We're in the middle of data cleaning and analysis, but do have a few preliminary results to share. When asked if the health department currently shares services with another local health department, you can see the responses there with the majority saying yes. Now, as Susan indicated, the definition here is a lot broader than what was used with the interviews. The interviews were primarily for the written agreements only, and the definition of shared services on the survey was the sharing of resources such as staffing or equipment or funds on an ongoing basis. The resources could be shared to support programs like WIC or environmental health, or organizational functions such as human resources or information technology. The definition went on to state that the basis for this resource sharing could be formal, either a contract or written agreement, or it could be informal, a mutual understanding or a handshake agreement. So really, with the survey in 2012 and the follow-up, we really wanted to explore the broad spectrum of shared service arrangements. So in 2012, we had 71% who responded that yes, they did share services according to that definition, so a slightly higher percentage in 2014. And generally, there is greater service sharing among local and tribal health departments in the programmatic areas, emergency preparedness and environmental health, compared to those organizational functions like communications, financial management, or HR. This is pretty consistent with what Susan found with the interviews and as well in the written documents, and consistent with our findings in 2012 and those with what Vest and Shaw found in 2012 and using the NACCHO 2010 profile data. When asked to the extent to which their health department's governing bodies, for example, their city council or county board, approve arrangements to share services, we see a majority of respondents saying that their governing bodies approve some or all of those arrangements. And when we look at the comments for this question, there's quite a few that noted that if there was a fiscal component to the arrangement or that dollars were exchanged, then the governing body has to approve that particular arrangement. Finally, when respondents were asked if the governing body discussed in the past 2 years or was currently discussing the potential for discontinuing with shared service arrangement, the vast majority said no, that they were not doing that, and that really that they're keeping them in place, and that's consistent with our 2012 findings as well, that there was, and also that there's minimal expiration dates that were noted on some of their arrangements. When asked if their governing body discussed or is currently discussing the potential for creating, we see a more equal split there in terms of if they were in the plans of developing a new shared service arrangement with another local or tribal health department. So we're just in the beginning stages of analysis of the survey results. Should have more to report. So with that, I'm going to turn it back to Susan.
Great,
to discuss our translations.
Great, thanks, Kusuma. So we did put a number of activities in this research project with regard to translation and findings, and this is being guided by our study advisory. We hope to be able to make some recommendations for practice and policymakers based on. We have 2 webinars planned. One conducted already in November with people here in Wisconsin to give some preliminary information about the study and the data we've collected at that point. Encourage people to complete the survey. I mentioned earlier that we are working on examining the legal aspects of these to put together a report or a research or a brief or something like that for the national. We intend to do some research policy briefs that we'll be posting website and also through the Center for Sharing Public Health. We are going to be doing a video format research brief for presentation. And we are in the process of submitting abstracts and hope to do conference presentation and write about this, the results of this. So I just wanted to point people, if you didn't already know about this resource, sharing. Gianfranco Pizzino is going to be speaking in a few moments. To this, and this is a project of the is a really good resource for practitioners to addiction. I just wanted to make sure you knew about this. And finally, I think that concludes our formal presentation. We'll invite your comments about the research, and there's our email addresses if should you like to get in touch with.
Thank you very much, Dr. Zahner and Dr. Madamala. We appreciate your presentation today. I will remind all of our participants to keep the phones on mute and the computer speakers on mute as we proceed. We're starting to get some questions in the chat box already, and we thank you for those, and we invite the rest of the participants to enter your questions as well. We will move now to some feedback from the two individuals who have agreed to provide a commentary on today's presentation. We first have Dr. Gianfranco Pizzino. Dr. Pizzino is the co-director of the Center for Sharing Public Health Services at the Kansas Health Institute. And we also have Linda Collin, who is the Director and Health Officer for the Oneida County Health Department in Wisconsin. So, Dr. Pizzino, would you like to start with the commentary for today?
Sure. Good morning or good afternoon, everyone, depending where you're sitting right now. And thanks for inviting me. First of all, I would like to congratulate Susan, Kusuma, and the rest of the project team. This has been a fascinating project, very well implemented. I think it's a good example of how practice-based networks can really contribute to improve the knowledge and our understanding on complex issues of public health governance. When I look at the results of the study, the first thing that strikes me is the high proportion of local health departments that report sharing services. And it also looks from your data that the interest is actually growing, and there are more and more governing bodies that discuss the possibility of new agreements. So obviously there is a lot of interest and attention there. Why is that? What's driving that? Well, again, looking at your data, it looks like improving capacity and effectiveness of public health services was reported as the most common motivation. Now, one thing to keep in mind is that your respondents were primarily or perhaps exclusively public health administrators. I suspect if you had asked the same question about drivers to policymakers, you would not have such a high proportion that would answer the same way, that improving capacity and effectiveness of public health services was their main driver. And cost saving would probably come a little bit higher than it has in your own data. So just a reminder that knowing who the respondents are is important in interpreting the data. And speaking about policymakers, your own data showed that in over 80% of the cases, they must either approve or disapprove some or all the agreements. So the role of policymakers in these sharing agreements has been often under-recognized, and I think a lot of the work that we have done at the Center for Sharing Public Health Services has actually revolved around how can we engage policymakers in a meaningful way in these processes. And the first way to do that, and perhaps the first and most important prerequisite, is to consider their own motivations. Once again, their drivers may be different from our drivers as public health officials. There is nothing right or wrong there. It's not that we need to convince them to adopt our drivers or vice versa. We just need to find a way to reconcile both an improvement in effectiveness, which is usually what's prompting a lot of us in looking for sharing agreements, and an improvement in the efficiency or a cost containment, which is usually where policymakers often come from, at least as a first step. We need to consider their involvement in this process. How do we involve them in a meaningful way? And speaking of the process, I kind of chuckled at the recommendation, just do it. And I think it reflects the good-hearted attitude of most public health people who are clearly people of action and they want to get the job done. And it's commendable also in this context if it's meant in the sense of don't be afraid and try, don't be afraid of the new. And in fact, as you have demonstrated again, this is nothing totally new. It's something that's been done for a long time. But there is a little bit of a risk in the just do it. Our research and our work have shown that projects will be more likely to succeed if they pay enough attention and they devote sufficient time to setting the ground rules first and setting the expectations for the results of the project and finding the common interests and common drivers among all the partners. That's true both for different jurisdictions involved and for the policymakers who have to approve those agreements as opposed to the public health officials who are more in the role and the position to implement them. So I support the just do it in the sense of don't be afraid to try, but I also want to caution a little bit into jumping into action too quickly without proper planning and assessment stages first. In looking forward, one of the things that we want to address in the upcoming couple of years with the continued support of Robert Wood Johnson Foundation is how do we define and measure success? Your project goes to the heart of the issue of measuring success when you actually ask people to report their self-perceived success of their projects. That I'm sure we all recognize that there are limitations in that approach. That's primarily a perception issue that doesn't really necessarily translate into hard data to show what the impact of these agreements is once they are implemented. So questions such as how can we objectively measure this impact of cross-jurisdictional sharing on the effectiveness and the efficiency of the system? How do we measure our return on investment? Perhaps more important from my point of view, our return on the objectives. How much closer does CJS put us in achieving the goals and missions of our agencies? How do we measure changes in the intensity, the quality, and the efficiency of the services that are provided through CJS as opposed to being provided by local health departments in isolation? So this will be hopefully the focus of our next couple of years, and I'm sure that we will try to tap on many of you and your experience in trying to address these issues. Thanks.
Thank you, Dr. Pacino. We appreciate that. We'll turn it over to the next commentator, Linda Conlon from Oneida County.
Good morning or good afternoon. Thank you. That were some really great points about shared services and also about our future steps that we need to take as we move forward in exploring more shared services. As a local practitioner, I'm very happy to be involved in this research project and research in general as a local practitioner. It's exciting to be involved in something that is shaping our future. What I want to talk about is a little bit about shared services and what was already stated. Shared services means a lot of different things to a lot of people at the local level. It can mean sharing equipment, resources, staff, technical assistance, and services. And as we look at that definition of shared services, which is really quite broad, we want to take a step back and really say, what is the benefit or the driver of a shared service agreement? And that benefit of an agreement really is that it gives structure to all the parties involved in the agreement and gives clear guidance. Agreements assist in getting everyone on the same page. It promotes transparency and assures all parties are getting what they want out of the shared service or agreement. And in addition to that, the Public Health Accreditation Board also promotes collaboration and MOUs and contracts and agreements as proof of collaboration. And as we had talked about before, there's a lot of guidance out there, and the website publichealthsharing.org really does walk us through a great summary of what we can do as we're looking at future agreements. And I think many of us in public health as practitioners have had informal agreements, have had formal agreements, and as we move forward with new agreements, we should look at this guidance to make sure that everybody is on the same page. Is there transparency? Do we need governance involved? What is the fiscal implications, legal implications? What are the timelines? These are things that I have learned through the process to improve our agreements so that really we are on the same page, and that when we enter into an agreement, we all understand what that agreement is, and we all have the same goal in mind. Because if we don't look and explore that goal, and we don't look and explore all avenues of why we're entering into this agreement, there's a possibility that somebody will be disappointed. And as we move on with the agreements, I really want to just touch base again, as stated earlier, what are the reasons why we should enter into an agreement? And basically, many times it's because we want to increase services or decrease duplication or increase capacity. But as others have mentioned, a main driver for local boards of health or governance is to provide a mechanism for the better use of our dollars, to promote that efficiency. And really what we're doing is not new per se, it's how we're doing it that's new. This is our new old way of doing business. So we want to think about ways that we can collaborate with our partners, such as the new opportunities that come on with grant dollars or requirements from the state that require collaboration, but also take a step back and look at our old projects or our programs that can be improved by entering into shared services. And as the study showed, many local health departments in the state of Wisconsin do participate in shared services, and I think we do understand that there's a whole slew of benefits for us to enter into those shared agreements. We just need to figure out how to proceed, maybe in a little bit more formal manner, and take a look at the Public Health Sharing website and those guidance that we can implement better service agreements. So from somebody at the local level who has several agreements with several different partners, the time now is to take that step back and say, how can we improve this process, and how can we improve the agreement to assure that all parties involved are getting what they want out of this agreement. And finally, I just want to say, as a member of the study advisory team, I'm excited to be involved in research at the public health practice level. Research is good. It's a benefit for the state of Wisconsin to be advancing public health through research. Thank you. I appreciate the ability to talk to you today about my experiences.
Thank you very much for those comments. We appreciate that. We have received several questions in the chat box, so we'll start with those for our presenters. Our first question is, with such a high relative mean score for performance, do you anticipate methodological challenges in parsing out performance characteristics?
I'll take that question, and I think the answer is yes. It is, luckily we do have a range. I mean, as I mentioned, the range of responses was from 0 to 5, so it wasn't, they weren't all clustered at the top. But the overall mean is quite high. And so that may mean that we won't be able to find results that might have hoped to, but I've got a really good statistician working with me. So if anybody can figure this out, Dr. Roger Brown, who's working with me on this aspect, I think we'll be able to find a way. But yes, it is a potential concern for the analysis as we had planned.
Thank you. The next question is, do you know or have a sense of the governance of the services? Were there mostly contractual arrangements, or did any of them involve shared governance of the services provided?
This is Susan again. So we have all of these documents. So the ones that we looked at, as opposed to the ones that are asked about in the survey, are all written documents. So and they all, or a lot of them are signed in some way. Some of them are not. So I think there's that's one of the reasons I'm consulting with the lawyer about whether we could come up with a way of understanding these agreements from sort of formal legal perspective, because there is a range in their format. I think in some ways, because they're written down and they're agreed to, there is some type of contractual relationship there then, some kind of legally binding kind of relationship for a lot of these agreements. But we hope to be able to find a way to categorize those more clearly. I think some of them do involve shared governance of the services provided. I'm not quite sure what you mean by shared governance, if you mean the policymakers from both counties or both involved in overseeing the services. This is some of the work that we still have yet to do to really understand what's there in the agreement.
I think there was a little bit of a clarification on that question that came through. It says, to be more specific, does one health department perform the services for another?
Yes, I think there are some examples in our agreements where that is true. There's also examples in the agreements where one health department hires a sanitarian, for example, who then provides the service in a couple of other surrounding counties. And those surrounding counties help pay for the cost of that person.
Okay, thank you. Another question is related to Dr. Pizzino's commentary. Are there any plans to expand the Wisconsin study to examine more questions regarding the value added for population health outcomes?
Could I actually respond to that?
Oh, absolutely.
Zahner again, because there is another study that's been funded by Robert Wood Johnson Foundation, and Justin Marlowe at the University of Washington is the PI for that study. And Dr. Marlowe is a public policy professor, and his experience is in public financing. And in that study, it's a 4-state PBRN study looking at cross-jurisdiction sharing. And so Washington, Oregon, New York, and Wisconsin are the states involved in that study. And we hope to, in that study, we plan to do the survey that we've done here in Wisconsin in those other states, so that we have 4 states worth of similar data from survey. And then also they have, they're using the IMPROVE measures for communicable disease, and we're going to try to look at communicable disease outcome data in these same locations across the 4 states, and also expenditure data from local health departments to see if we can figure out a way of looking at cost and outcome measures associated with shared service areas in which there are shared services. So that study is just got underway in September, part of the directive call for proposals that put out by Robert.
Thank you. I believe we have another question coming in on the chat box, but we'll also open the phone lines if anyone else that has participated in the webinar would like to ask a question of our presenters or our commentators. I do have one question for our presenters regarding the slide where you listed the motivations for the shared services agreements. The top one that you have listed there, it's not one of the highest responded, but it says meets requirements. And then you also talked about under administration and planning that strategic planning you had often found was something that had been used with a shared services arrangement. And I'm wondering if, as I look at those two things together, did you see very much activity going on with specifically regarding accreditation activities? Certainly strategic planning is one, but possibly community health assessments or anything else to do with accreditation that was being employed through a shared service arrangement?
That's a really great question and something I'm really looking forward to looking at. Wisconsin, as some will know, has been somewhat of a leader in our local health departments in pursuing accreditation. We have a number of our health departments now that are accredited, and I was hoping to include that as a variable in some of this analysis to see if we can tease out whether there's differences in shared service agreements across health departments that are or are not accredited. So that's one way we can look at the influence of accreditation on this process. Some of the agreements are about community assessment, but what I can't tell you today is whether those agreements are as a result of or are even between health departments that are accredited or aren't. Perhaps Linda Conlon could comment, practitioner.
I do know that in my health department, we do collaborate with another health department in our community needs assessment. In the state of Wisconsin, we often find the smaller health departments that are geographically close do combine for community needs assessment. A lot of times then they end up with separate plans, but the community needs assessment process is a collaborative shared service effort. And as far as being between accredited and non-accredited health departments, I don't think the driving force was the accreditation process. I believe the driving force for that shared service was because geographically and population-wise, we had a lot of similarities, and then size-wise, we often do not have the resources to conduct community needs assessments independently. And I am accredited as one of the accredited departments in the state of Wisconsin, and for us, we partnered with a much smaller health department, and it often assists them as a peer mentor as we go through the community needs assessment process, because we are looking at the accreditation standards and the measures and what do we need to meet those. And then by virtue of us doing that, it does assist that other local health department in that area when they decide to apply for accreditation.
That's very helpful. Thank you.
Yes, Kusuma, Madamala, I know in the survey we also asked motivations, and to meet volunteer accreditation standards is one of the response options. And we haven't gotten to that data yet to examine it, but in 2012, it wasn't as frequent of a motivator as, making better use of resources or provide better services to the population. So it wasn't as high as a motivator at that time, but we have yet to examine it for this round.
Any other questions for our presenters? Just to follow up on the last question, I'm wondering if any of you have seen any health departments who are actually sharing an accreditation coordinator, the person who is guiding the accreditation department, the documentation for accreditation and those kinds of activities. Have you seen any health departments share that position?
This is Linda, and of the accredited health departments, there's no one that has shared an accreditation coordinator. I do know in the state of Wisconsin that the accreditation coordinators share materials and documents, and they're always in contact with each other. And as far as what I've heard, I have not heard of even the smaller health departments sharing an accreditation coordinator.
Okay, I appreciate that. Here in Kentucky, we also do the same thing that you're describing as far as sharing materials and information and that sort of thing, but we've had a request to consider doing a project with a shared accreditation coordinator. So we may give that a try and be able to let you know how that worked out.
I think it's a great idea.
Thank you. See, I think we've got another question coming in on the chat box. Anyone else on the phone lines would like to ask a question? We've got about 5 more minutes today.
Hi, this is Ann Kelly at University of Kentucky. I'm just wondering if Susan and Kusuma, if you could give us a sense of when the results will be available, or you might be ready to share some longitudinal comparisons on the data that you've collected.
I think the answer to that is we have abstracts in for Keeneland Conference, which should be coming out to people, let people know whether they're accepted or not later this week, as I understand it. Also, abstracts in for Academy Health. I think Kusuma is planning on the presentation of the comparison at the Academy Health Public Health Interest Group meeting. I think by that time we will have pretty complete results.
Great,
Kusuma, I didn't want to speak too much for you there.
No, that's
We also have submitted an abstract for the NALBO meeting, understanding Gianfranco's perspective that policymakers are really very important in this particular aspect of public health, and hoping that perhaps we can share this information at that meeting, which is a national meeting of boards of health.
We did receive a comment regarding the shared accreditation coordinator. The Central Massachusetts Regional Health District shares one accreditation coordinator across its 7 towns and cities. They are seeking accreditation as a region, not as individual towns. So that's good information to have. Thank you for that. It looks like we're just about out of time today, so I will thank our presenters and our commentators again today for all the great information that was shared, as well as those of you who posed questions. The last slide that should be on your screen now is reminding you that we have archives of all of our webinars available on our website, and you can see the address there. We have an upcoming PHSSR Research in Progress webinar on February 19th from 1 to 2, and the topic will be identifying and learning from positive deviant local public health departments in maternal and child health. So again, we thank all of you for your participation today and hope that we see you on the webinar later in this month in February. Thank you.